Okay, so just doing a voiceover here on this chest tube lecture. Some of this will be review from what we had talked about Friday when we were in class. So again, supplemental reading would be chapter 22 in white and chapter 5 in piercing. Also keep in mind, check out the additional resource reading that is also listed under Blackboard under this particular day. And I also posted my talking points that I went over in class. Okay, so just again a little review of how the lung is covered with the visceral pleural, and then the parietal pleural lies the chest wall or chest cavity. We have always pleural fluid stop. Is normal, which helps allow both the surfaces to glide against each other smoothly during the inspiratory and expiratory phase. The pleural space then function is to hold the two pleural spaces together by creating a vacuum, basically, that helps keep the lungs inflated. So when that is not maintained for some reason, we have an excess of fluid or air gets into that pleural space, then we have trouble. Generally there's about 50 cc's in the pleural cavity, which is normal amount of pleural fluid, and if we have an excess amount, it can cause our lung to collapse. So a couple different terminologies here. Again, a pneumothorax is basically a collection of air in the pleural space. It is one of the most common reasons that a chest tube is placed in the critical care setting. A tension pneumo occurs when air accumulates in the pleural space, causing a mediastinal shift, pushing on the heart, the great vessels, and the lungs towards the unaffected side of the thoracic cavity. Can often be caused by positive pressure ventilation. Then we have the hemothorax, which is a collection of blood in the pleural cavity, and then a hemopneumothorax then would be a collection of both air and blood in the pleural cavity. Having to break up a dog fight. Alright. I tell you, it's non-stop. It's like they're kids. Like they know totally when I'm busy and I can't give them my undivided attention. Alright, so continuing with other indications for our chest tubes, again, pleural effusion would be an excess of fluid in the pleural space. That chylothorax, which is the accumulation of lymphatic fluid known as chyle in the pleural space, and then empyema would be pus from an infection like a pneumonia that could also occur in the pleural space. So just a couple different pictures here. We have just a regular pneumothorax here on the left side. You can see where the chest tube is being placed right there, and then the lung being re-expanded. And on the other picture, you can kind of see the tension pneumothorax. So basically the affected side has the buildup of the pressure, and then it pushes on the unaffected side, which then can compromise your cardiac output. So a tension pneumothorax can definitely be an emergent situation. And then the pleural effusions, we generally would like to get the chest tube placed between about the 4th and the 5th intercostal space there on the mid-axillary line. Again, I mentioned before in class that occasionally you might see it placed anteriorly between the 2nd and 3rd space, anteriorly about mid-clavicular if it's air. Another picture here of a pleural effusion on the right side. So another indication for chest tubes would be pleurodesis. So this is kind of more of like a therapy. I mean, they would So pleurodesis is done. It's a sclerosing agent that's actually, they put it into the pleural space, and it kind of causes the visceral and the parietal pleural to kind of adhere to each other. It's generally done when there's been reoccurrent pneumothoraces for some reason and the lung just won't stay up, so they kind of put this substance in the pleural space to help it kind of stick together again so it quits collapsing. And then another thing that they might use a chest tube for is to administer chemotherapy. Some of the different causes of having air or fluid in the pleural space. We had talked about this also in class. Trauma, I mentioned, rib fractures could be from kind of more of a blunt trauma like a fall or auto accident. So the trauma itself, the rib fractures could also puncture the lungs from the same incident. Sorry, you can hear my dog whining. One wants to play with the other. Penetrating wounds would be like a knife or a gunshot wound. Other causes could be medical or surgical complications. Again, the high ventilating pressures, so positive pressure ventilation, some different types of line insertions like a central line, thoracic surgery, so like an open lung reduction, though they really don't do those too much anymore. I mean, they do the reductions where they actually take out part of the lobes, but an open lung biopsy they don't do as much anymore with the new technique with the EBIS bronchoscopy. They're able to get out further in the periphery. Let's see, so thoracic surgery would also include cardiovascular, like bypass surgery, heart surgery, CPR can actually cause air or fluid in the pleural space. You can puncture a lung, and again, during surgery, the lung or the chest wall being biopsied, like I mentioned. So more of like the empyema might be related to infection or disease. Pneumonia sometimes can cause a pleural effusion, so can cancer. COPD, CF, tuberculosis, pulmonary embolism, or fungal infections. So these could all be different causes. And again, the CV problems, cardiovascular problems, such as heart failure. If you have to go in and do like a pericardiocentesis or something, you might accidentally puncture the lung. So these are all different examples. Alright, here again is that picture that I had shown you in class. This is again a smaller bore chest tube, generally done for air only, and so this one is more anterior. To me it looks like it's a little bit lower than between the second and third intercostal. But again, it depends where the pneumothorax is on chest x-ray. Of course, it could be kind of fed up, the tube itself might be actually up further. So even though it looks like it's below the nipple line there, it actually might be inserted into the chest wall further up. And again, this is called a Heimlich valve. It has just like kind of this little rubbery, like fluttery valve here. So it just allows for air to escape and prevents air from going back in. And this one looks like it is probably attached to a little bit of suction here too. These are the video clips that we looked at. I know we looked at the one of them is just kind of more didactics. There's a few pictures, it's just more about the technique. But then the other one has the actual video of them inserting that chest tube. So there are certain risks associated with chest tube insertion. Bleeding obviously being one of them. Infection. Keeping in mind, if you didn't start with an empyema, you might end up having one because having the chest tube in itself, it's invasive, and so the longer the tube is in, the the greater the risk for infection. Subcutaneous emphysema would be that collection of the air underneath the skin, which often happens. Generally, it is just kind of self-absorbs after a period of time. However, it can also travel. So sometimes it's just kind of localized around the chest tube insertion site. Sometimes it's not noted very well because there's the bandage and stuff covering it. But if it travels kind of outside that bandage area, or when you go to listen to the lungs, you'll get used to these different sounds after practicing for a while. But I've definitely picked up on it. Even just kind of listening over the bandage site, it's just like this weird kind of crackly, really like the Rice Krispie popping sound. And what you do is you take your fingertips, and you just kind of walk them over the chest area where you expect the sub-Q, and you actually can kind of push on the little air pockets there. And again, it can travel like up into the neck, travel up into the face, the eyelids, and really be kind of distorting to the person's appearance. Let's see, what else do we have? Lung trauma and perforation of the diaphragm could actually happen when you're inserting or during removal of the chest tube. Bronchopulmonary fistula is an abnormal connection between the air passage and the membrane that covers the lungs. Sometimes then they have to actually leave the tube in for a while till it's healed. And of course, malpositioned, the chest tube can often get pulled out, when they're turning a patient or moving a patient. Just you have to really be careful with them. So that's a pretty the most common complication. This again is that drawing of the or illustration of the 3-bottle system, and that other, let's see, one of the additional reading sources that you have, if you click on it, it'll show that man that's just kind of chilling out with the different bottle systems there. So that kind of explains the first one being the collection chamber, the second one being the water seal, and then the third one being to suction. So that system, this old-fashioned system, is kind of what has led us to the newer system, and this is exactly what you saw in the classroom, the atrium system. And some of the different, after you guys left, I was putting stuff away, and I was noticing this was pretty cool. So when there's actually a vial of water, sterile water, that was attached to the back of this, and there's a little port up here, you can't really see it, but on the top there where you would actually insert that. Basically it's not a syringe, it's like we call them bullets, like a large bullet that probably has the 20 cc's, 20 centimeters of water in it. I bet you it's 20 cc's. But anyway, you would go ahead and put that in this water seal column, so it already comes with the water. So that's kind of cool because the opening is pretty small, and then you just kind of stick the little end, kind of like a syringe, and fill it up that way. So I thought that was kind of interesting that I found that kind of on accident as I was putting it away. Like I said, I have really never assisted with, other than holding that one gentleman's hand when he was having his chest tube put in, but then the nurses usually just take it from there, and then we just kind of help monitor it to being aware that it is there, especially when we have ventilated patients. So again, the chest drainage unit has these 3 different collecting chambers in it. We're doing it either for air, blood, or different effusions. So again, we have the fluid collection chamber, the water seal, and the suction control. So I just kind of expanded a little bit more on this PowerPoint. Again, the fluid collection chamber is generally often blood is in there. It can be kind of purulent-ish blood, sometimes it's kind of tannish blood. It's just depending on what they're draining. So it's important for us to be aware, but the nurses definitely are doing the documentation, unless that happens to be your role at your facility, on how much output there is. If you have greater, I think I read that, greater than 100, if you were to have greater than 100 mils in like an hour, then that would be concerning. I know I read that someplace. I have to look and see again. I'm going to put you on pause and let me check that out. Yeah, I found it. It's actually on one of my slides coming up. So yeah, I did read that today. Greater than 100 mils per hour. I mean, initially you might have that dump, depending on, what's there. But then if it, you just want to keep monitoring it. So if it picks up for some reason, it would be concerning. Again, looking at the color and the consistency of the fluid. The water seal chamber provides that one-way seal, allowing the air to escape the pleural space but not to re-enter. It's generally filled with 2 centimeters of water. Again, the greater than 2 centimeters is going to prevent air from escaping the pleural space. I will fix that after I'm done recording. And then less than 2 centimeters could actually allow air to enter the pleural space when you take a deep breath. Air bubbling through the water seal chamber intermittently is actually normal. When a patient breathes or coughs, especially if they take a deep breath. If there's continuous bubbling, you want to make sure they're not having an air leak, or maybe your suction is set too high. So that's kind of part of the different troubleshooting that you might be aware of and kind of keep an eye out for. You might just mention to the nurse, was it bubbling like this before, or was the suction turned up too high, or is it getting an air leak? And then again, the suction control, that is the most distal or the most furthest away chamber from the patient's chest tube insertion. Again, it's generally filled with about 20 centimeters of sterile water, which is then equal to 20 centimeters of water pressure. The higher the water level, the greater the suction. And then again, it is actually connected to the vacuum suction that is at the bedside. So different troubleshooting. If you are on mechanical ventilation, you need to make sure that you might have to adjust the tidal volumes, or possibly switch to a different mode of ventilation to get your desired ABGs. If you have a really huge leak, and that's probably one of the times that I actually saw the bifurcated tube, where they had the Carlin's tube, which is something that you'd use when you independently lung ventilate somebody. So you would actually have 2 ventilators, one ventilating the left lung, one ventilating the right lung. If you had a huge chest tube leak that you just could not control, you could not manipulate, you couldn't change it, the physician's done everything they can, and you're just losing too much volume. And so the air is going to go out the path of least resistance, so you're going to lose all that air out the chest tube, out of the hole there. And so a leak just means you don't have a really good seal or a good placement. So maybe there's like some kind of, maybe a large BP fistula or some necrotizing situation going where, well, in that case I would think they would just do a lobectomy and take out part of the lung. But that is where I have seen the independent lung ventilation done. Also there you might have to just close the hole, so it might require some surgery. So yes, that low return tidal volume during mechanical ventilation means definitely that you have lost your volume. So due to the chest tube or tubes, you might have 2 chest tubes in, and you might have that one has a little leak and one has a bigger leak. So, and it might be on both sides. So just kind of depends on what's going on with the person and why they have the chest tubes in to begin with. Again, excessive bubbling could be you might have too much suction from the wall source, so you want to reduce it till you have gentle bubbling. A little YouTube video on that. Excessive or continuous bubbling in the water seal, again, that can be a loss of air or a leak. Then they kind of go through the troubleshooting a little bit more in white about where you could kind of clamp the tube and kind of see where, if the air is coming from the patient, or if you have connections, bad connections within your system, within the chest tube itself or the chamber, or maybe just something came loose in the connections. If there's no bubbling in the water seal chamber, then you want to increase the suction a little bit, or make sure that you have enough water in the water seal chamber. Titling, I think I finally have this straight. So titling is normal. You should see some fluctuation in the water seal chamber, and that is called titling. So during spontaneous respirations, the water level is going to rise or increase during the inspiratory phase, and it will fall during exhalation. And when a patient is receiving mechanical ventilation, the opposite is going to be true due to the positive pressure ventilation. So during inspiratory, the water level is going to fall due to the positive intrapleural pressure, and then the water level will rise during exhalation. If the lung is actually totally expanded, you might not see titling. You also want to make sure that your tubing isn't kinked or clogged up with any type of fluid buildup. So just always, be aware again of that chest tubing is generally, I think I read like 6 feet long, and you could see that it was quite long when we were in class. Sometimes when patients get turned or moved, they might be laying on it and pinching it off. Also, when they put up the bed rails, those side rails, that's a really good way to take a chest tube out by getting it caught on that, or possibly you could get pinched when you raise the bed rail back up. It can get kind of lodged in between the mattress and the rail itself. So just really being aware of everything. I mean, that's true about with IVs, the IV lines, any other monitoring lines, of course the vent circuit, all that kind of stuff. You really need to have good situational awareness on what is going on around you. Just don't get like super focused on one thing, because there's a lot to be aware of. There's a lot that can go wrong. All right, again, other troubleshooting, if there's nothing in the collection column, possibly there's just nothing there anymore, but you want to make sure your suction is set appropriately. Make sure that the system is below the chest tube insertion site, because it is gravity dependent. This is where I read if you have greater than 100 mils per hour, there might be a hemorrhage going on. Just making sure they're not dumping out a bunch in their chest tube, because overall that's going to hurt their blood pressure and their heart rate. So you want to make sure that you're checking all that too. You don't want them to lose too much fluid. So part of the removal is that you have to eventually, they turn off the suction, they just keep it to water seal, and eventually they clamp it. If there's no signs of distress, they definitely want to do a chest x-ray to make sure that the lung is re-expanded, and then hopefully it will be set to be removed. So they remove the dressings, remove the sutures, clean everything up, have the patient take a deep breath, and then they pull out. It should come out pretty easily. I've seen them remove them a few different times. You'll be surprised. Oh, this video is pretty good. Watch this one. The guy's like, oh my gosh. And it was probably in there a good 6-8 inches, I remember. He's kind of a younger guy, but yeah, if you can watch that, that's a good video. And so this is kind of where they're showing, so they're kind of holding pressure there a little bit, kind of putting a gauze, and then with the one hand, and then the other hand then is getting ready to pull them out. And then obviously again, you're monitoring your patient for any signs or symptoms of respiratory distress. They will definitely get a chest x-ray probably after a few hours to make sure that they maintained, but if they're having any more chest discomfort or shortness of breath or their SAT start dropping, then we have to be mindful that possibly their pneumo is back. And then my last page is my references. Okay, hopefully you found that helpful. We will talk next time.